I welcome us all to yet another edition of the Kunle Hassan Eye Foundation Academy Founders Lecture Series. Today we'll be looking at the topic, Building Generational Partnership in Healthcare. My name is Frances. I work with the Kunle Hassan Eye Foundation Academy, and I'll be our anchor for today. Before I welcome our speaker, I would go ahead to do a brief introduction about the Kunle Hassan Eye Foundation Academy. It is a part of the Eye Foundation Eye Care System, which formerly used to be known as the Deseret Community Vision Institute. The Deseret Community Vision Institute was established in 1997 as its training arm to anchor training for ophthalmology, residents, fellows, middle-level ophthalmic practitioners, MLOPs, optometrists, amongst other allied healthcare professionals. So this is the 19th lecture of the Founders Series, and in the past, we've had 18 lectures in the series covering various topics that can be found on the Kunle Hassan Eye Foundation Academy YouTube page. So presently, I'm going to take us on, I'm doing the brief welcome, then I'll do the introduction of the speaker, then we'll take the presentation from the speaker, we'll have a Q&A session, and then our closing remarks. I'll go ahead now to introduce our speaker for today. Our speaker for today is Mr. Dele Salami, who is the Chief Executive Officer of the Campbell Heights Investment Limited. He is an alumni of the Lagos Business School and a graduate of the University of Ibadan. He holds a master's degree in public administration and a postgraduate diploma in education, both from the University of Lagos, Nigeria. Mr. Salami has garnered extensive experience in human capital management, learning and development, marketing, sales, operations, and distribution logistics, financial and investment management as well, and business corporate leadership in the education, manufacturing, and healthcare sector. He was the managing director and chief executive officer of the Health Partners from 2013 to 2019. He joined Health Partners Limited as the executive director and the chief operating officer in 2008. Mr. Salami was initially employed into the Lagos State Teaching Service in 1995. He started his corporate management career at Dunlop Nigerian PLC, where he joined the HR division as factory personnel officer in 1995. He subsequently served in several positions. He was promoted to senior management in 2001 as recruitment and manpower development manager. He was later seconded to marketing division at National Sales and Service Manager from 2003 to 2006. On successful turnaround of Dunlop sales, service, and distribution operations, he subsequently became the divisional head, Human Capital Management, and Director, DN Pension, which is the Dunlop Nigeria Pension Trust Limited. He later served the Dunlop Group as Divisional Head, Marketing and Strategy. Mr. Salami voluntarily retired as the MD CEO in July 2019 from Health Partners and is currently a non-executive director of Health Partners Limited and the chief executive officer of Campbell Heights. Furthermore, he's on some of these organizations, the Sapida Microfinance Bank, the DSH Healthcare Limited, the I1C Bureau de Change, the Deseret International Hospital Limited, and he always sees himself as he's a student of business and he loves teaching. Today, our speaker will be taking us on the lecture, on the topic of the lecture called Building Generational Partnership in Healthcare. So I'd like to welcome Mr. Dele Salami, but just before he comes on, just a few house rules, please. We ask that this session is recorded and we require everyone to have their microphones muted, their cameras turned off while the speaker is presenting. And at the end of the day, we're going to take questions. If you have any questions, please feel free to type them in the comments box or raise your hand after the speaker is done talking and you'll be called upon. Thank you very much. So I'll hand over the floor now to Mr. Dele Salami. Thank you very much.
Distinguished ladies and gentlemen, good afternoon. hope you can hear me.
Yes, we can hear you.
Thank you very much. Thank you
We
very
can
much.
hear you, sir.
Thank you.
Very much. Well, I'm very pleased to be here this afternoon. I must immediately thank Mrs. Harriman, who had made a call to me sometimes in August that she wanted me to talk about a topic for discussion under the KEFA institution. Initially, I declined. I thought I didn't have the capacity to do so, but she kept pestering me. Finally, I gave in. I sat back, did some paperwork, read across the lines, and at the end of the day, I came up with this presentation. Let it be on record that I am not a doctor. However, I'm a student of healthcare business. Let it also be on record that what I'm going to say today are not necessarily new. I've worked with doctors for a long while. Indeed, I was born into healthcare. My father was a pharmacy technician. He was a community doctor who were the only set of people that were doctors then, because I recall that in the entire Ijebu division, it was only Dr. B.O.B. Rufai who was a doctor. All other persons were nurses and pharmacy technicians under him. His office was in Ijebu-Ode, while my father was posted to Dogbolu, Idlefun, Ayepe, Okunwa, and later Ijebu-Ode. So I lived all my life in staff quarters of health centers. And therefore, most of the things I'm going to be saying today are based on my experiences of working with doctors and healthcare workers in the last 60 years thereabout, when I became conscious of what learning is all about. Particularly in the last 17 years, I have worked with healthcare workers as executive director and chief executive of Health Partners HMO. And they have taught me a lot of things. And I'm going to be using the watch of the doctor that I've worked with to tell the time today. Let us also be on record that when I completed this set of slides on Saturday, I sent it to Dr. Denilo to vet, to help me to edit, and he ran through them and felt that it was fit for purpose. I will, however, acknowledge that if there's any mistake in this slide, in this presentation, it doesn't belong to Dr. Denilo. The mistakes will belong to me. I take full responsibility for any errors of omission and commission, and I also acknowledge the contributions of my team in Health Partners who proofread. Dr. Michael Isaac, the Chief Executive of Health Partners, who also proofread this presentation. The topic of today is building generational partnerships and wealth. Because at the end of the day, we are all in it for money. The government wants tax, it's money. The employees want salary, it's money. The shareholders want dividend, it's money. Everybody is in it for money in one way or the other. So there will be no generational partnership if there's no wealth. There will be no generational impact if there's no wealth. So I said to myself, this discourse will be about how to build generational partnerships and wealth in the Nigerian health space. I have seen a lot of doctors rise and fall in my career. At least at my time I was conscious as a young man, I've seen hospitals start and have seen hospitals failed, even before the proprietor's death. So today's discussion, therefore, is a moment of truth. It's in the light of truth based on my experience. As you are aware, people generally hate the truth. but the truth does not care. So the theme of today's discussion is to break habits of our doctors and healthcare workers, to build new staminas, and to boost the energy. It is to sensitize our doctors and medical practitioners to stop holding on to old habits, because the cost of holding on to those old habits are very damaging. To learn to let go and to learn to see opportunities where there appear to be none. As you are aware, and as we are all aware, the key issues in the healthcare space are well articulated. Our population has grown steadily. According to Peace Warema, it is expected to grow to 295 million by 2036. Government allocation to healthcare is certainly inadequate. The burden of healthcare is being heavily carried by private sector providers because of the failure of the public health system. It may interest us to understand that of the 40,000 healthcare facilities in Nigeria, about 30,000 actually belongs to government. And those 30,000 facilities are not really rendering any tangible service for the kind of investment that have been put to it. It is the 10,000 private sector hospitals that are actually struggling, that people are actually trying to patronize to get value for their money. There is inadequate access to financing, and of course, there are very low standards of healthcare. According to Ngozi Okonjo-Iweala, clearly 49% of Nigerians do not go to hospitals. 49% of Nigerians do not go to hospital. Only 24% go to neighborhood chemist, that is patient medicine store. Those guys do not have a requisite knowledge and understanding of what medicine is, but they are selling drugs, they are selling medication across the place, in motor parks, at ridiculous locations, at bus stops.
Please, I kindly ask that if you are not speaking, please mute your mic, please. Mr. Charles Oji, please mute your mic.
17% of Nigerians are patronizing herbalists and traditionalists. They drink agbo, and about 8% are prayer warriors. They believe it is not their portion to be sick. So when they fall ill, they either go to the mosque or the church, or back to the babalawo, or back to the native patient medicine store. Only 51% actually patronize one form of licensed health practitioner or the other. That is, 15% go to pharmacists, registered pharmacists, 23% go to public hospitals, and 13% go to private hospitals. Ecology of clinical practices in Nigeria. As of mid-2021, 40,368 healthcare facilities reportedly operated in Nigeria, business day, April 9, 2024, including 10,900, representing 27% private sector-driven hospitals and clinics. However, about 90% of these private sector hospitals operate as sole proprietors and are generally ill-equipped with poor business continuity plans. Therefore, most of these hospitals die before or shortly after the demise of their proprietors. Indeed, about 4,000 of these private sector hospitals have reportedly shut down between 2021 and 2024 due to economic pressure. We appear to be in an organized disorderliness, particularly when you look at the fact that there is acute shortage of physicians. 66,000 physicians were reportedly licensed as of 2024. As of today, NMA is claiming that 30,000 doctors are practicing, while the Honorable Minister Ali Pate claimed that 55,000 are in practice. All of this goes to show that we are in a disorderly chaos, an organized disorderliness. Patient load is doctor-patient ratio is very high as 49,000 in Zamfara for general practitioners. I went into literature and I stumbled on a PricewaterhouseCoopers document with respect to the kind of things we should be doing in healthcare business. And PwC identified 4 categories of hospitals that we should be promoting. And they call them the product leaders. These are top-notch institutions that are highly commercialized because they have strong investment in technology. Then the experienced leaders. These are social institutions for social entrepreneurship for budget-sensitive community members. The integrators and the health managers are actually about the public sector. And today we are not talking to people in the public sector. We are probably talking to people in the private sector. So we'll be concentrating on the first two, the product leaders and the experienced leaders. In the product leadership segment, clearly, permit me to identify Iwosan Lagoon as a product leader in general medicine and Eye Foundation Hospital as a product leader in the specialist segment of medicine. With respect to experienced leaders, that is those who cater for budget-sensitive community members under their social entrepreneurship system, I clearly see the Eye Foundation Community Hospital in the Ijebu-Mushin in this category. The typology of hospitals, I've already alluded to it in the previous discussion. So on the previous slide, I'm not going to waste time on this. But the important thing on this note is that the age-long one-man practice of medicine as a business is now inadequate and unsustainable. We need new paradigms today. Key issues in healthcare delivery. The healthcare system in Nigeria is yearning for significant changes. We need to move from fragmented to institutional entities. Medical practitioners are encouraged to come together to build capacity. And the future that I can see immediately, amongst others, but I'm going to focus on group practice today. Our discussion today will be focusing on group practice. As a student of healthcare, I have been privileged to have understudied 5 institutions of group practice. I was on the Nigerian South African Health Business Summit in Johannesburg in 2010. And I visited, as part of that program, 2 hospitals that are into group practice. One is a specialist clinic, the other one is a general practice clinic. The specialist clinic is called the Pain Clinic in South Africa. The Pain Clinic was initially established by just one person, but after some time, he started taking residents into his practice. It's based in Sandton. The headquarters is based in Sandton in South Africa. He started taking in residents into his practice, and before we know it today, by the time I just checked last week again, there are so many pain clinics in South Africa, whereas the pioneer has moved on. The second hospital that I understudied along with the team that went to South Africa for the 1-week Nigerian South African Health Business Summit was the 4-way hospital, also in Sandton. The 4-way hospital is also a group practice hospital where doctors from different specialties come together in one building. If each specialty had their own CEO, chief operating officer, each specialty, I was particularly interested in radiology. The chief executive officer, the chief operating officer, and the CFO of the radiology unit, I had extensive discussions with the guys. The doctors were doing their businesses, yet each of those units in that hospital had and administration to back what they're doing. Because at the Fourway Hospital then, at the Fourway Hospital, the radiology department had 5 partners or in that one department. Some in general radiology, some in interventional radiology, and so on and so forth. I was also privileged to have understudied the Studley Clinic in Bow, London, as well as the Wellington Way Hospital in Bow, London, which is also manned by a Nigerian, Dr. Dimeji Amolutu. And I can tell you the transformation that has happened in those practices. Of course, at home, I am certainly conversant with Eye Foundation Hospital. The reason why we got to be global is very clear. In the New World Order, globalization has triggered a lot of issues, including, but not limited to, reverse opportunities. And when I say reverse opportunities, we will see that we are leaving Nigeria. We call it Japa, that other people are coming to Nigeria. Asians in particular, the opportunities that we did not see, the Asians are seeing them. There are a lot of conflicts. So Boko Haram and other things are not necessarily new, because each time I hear conflict and war, these are now parts of our life in the New World Order. Of course, there are so many talented people. We need to deploy digital lifestyle to bring them together, because they are all lonely. They are looking for opportunities to participate, but they do not know how to connect with ourselves. This call today is a major opportunity to also connect with the lonely crowds of talents across the world. In terms of technology convergence, on our phones, artificial intelligence, some of the data for this presentation today, I had to go do this research by myself. The concept of good practice. Certainly, the good practice is not new. It is to enable the teams to equitably share the burden and benefit of partnership. And it is not new. The playbook for good practice is already well articulated and can be easily adapted in medical practice. For example, the purpose of good practice is to trigger merger and acquisition that should lead to increased capacity utilization, productivity, patient load, and value creation. To enhance clinical governance, facilitate international recognition, accreditation, and research, attract funding for capital investment in equipment, infrastructure, and training, specialist diversification, as well as supply chain integration. If you look at the picture on this slide, you will see that it tells us a story of 6 doctors coming together with different capacities. And if we pull the capacities of these 6 doctors, one bringing 6 talents, another one bringing 3 talents, another one bringing 2 talents, another one bringing 1 talent, and so on and so forth. It will increase the combination of 6 doctors by this little program, by this little picture, is to increase the capacity of 6 people by 350%. Expectations will increase by 350%. Exploration will increase by 350%. Experience will increase by 350%. When just 6 people combine, instead of mushrooming our facilities, instead of everybody wanting to become managing director, chief executive, chairman, chief executive of a mushroom hospital, if 6 of us come together, we are going to increase our capacity, our install capacity by 350%. In industry, Procter & Gamble were 2 people. Michael Marks and Tom Spencer were immigrants. Michael Marks was an immigrant. Tom Spencer was an account clerk. So the little money that Michael Marks brought, he started trading and he invited Tom to help him manage his finances, and they combined. Unilever, these are a world-class example of group practices. Unilever was established by Margarine. That's why you see how Margarine as one of the brands, and the Lever brothers. Elliott and Packard were colleagues. They met at a vacation and decided to come together to a good practice in the ICT sector. Dan Tata and Sawo, in order to break the monopoly of Julius Berger, was established in 1976 by collaborating with his German friend, Mr. Sawo. Of course, in the accounting realm, PricewaterhouseCoopers, Akintola Williams, we cannot remember any other one, Akintola Williams, our former Attorney General of Western Region, Olaniwan Ajayi, established his practice in 1962. And today, the fourth generation is managing this institution after Olaniwan Ajayi, and so on and so forth. Therefore, for us to say that a business, a practice has generational impact, we are saying that the practice must have had uninterrupted operations for over 30 years. Original founders and owners must have existed in the institution. And all of these original owners have existed in the institution, except Dia, Fatimileyi, and Co. All the other ones, original owners have existed in the institution. So we now go to medicine. How can we apply all of these issues to medicine? Because we are going to be talking to ophthalmologists, we are going to interchangeably talk about medicine either from a general point of view or from an ophthalmology point of view. According to Fatima Kyari, about 4.2% of Nigerians are reported to have ocular challenges by our estimate of ourselves and our team in 2009. That team also identified high-risk areas and low-risk areas. The high-risk areas, northeast at 6.1, northwest at 4.8, and southeast at 4.6. Whereas southwest, south, and the north central are low-risk areas. I went further to go and search. I mean, what is the solution to this risk? And the Federal Ministry of Health in the iHealth strategy document for 2024-2028 had categorically stated that 84% of these conditions are subject to timely and professional intervention. Are we having timely and professional interventions? We are unlikely, distinguished colleagues and listeners and participants on this call, because we do not, there is evidence that we do not have enough resources to intervene adequately. It is true that the population of Nigeria has grown steadily over the years. We therefore project that the 4.2 million identified by Kyari and her team in 2009 will likely grow to 9.4 million in 2026. Doctors have run away. As of today, a total of 860 of practitioners are on OSN register. These figures are interpolated. We did not have access to full figures, but we used conference data. We were able to get report of conference reports, OSN conference report, and look at the data of attendance. And we used 40% of the attendance as projection, that 40% of all available practitioners will attend the conference, and we came up with these figures. From what we saw, 75% of all available ophthalmologists in Nigeria are in the low-risk areas, and only 25% are available in the high-risk areas. This is a disaster waiting to happen. I call it reverse discrimination. Those who need ophthalmologists do not have it. All the ophthalmologists are seated in Lagos, Abuja, and Port Harcourt. And this is the data I was referring to. According to Peace Nwarema and David Edokpa in 2019, it was projected that our population by 2036 will be 285 million. And with this, even though Northeast is high risk, only 6% of ophthalmologists are present in Northeast, whereas Southwest is low risk, only 37% of ophthalmologists are present in Southwest. A disaster is waiting to happen. Blindness is likely to increase in the Northeast, Northwest. The patient load, like I said, the patient vulnerable group is likely to, to increase from 4.2 million in 2009 to 9.4 million in 2026. This is how we got the figure. The figures are well articulated. We use the population estimate by Peace Nwarema and Edokpa to project these figures. What are the opportunities that we have seen? Even though the Northeast and the Northwest regions are high-risk zones, they appear to be grossly underserved, while the Southeast is marginally served. The potential patient load per ophthalmologist in the Northeast and Northwest is about 36,000 and 53,000 respectively, while the Southwest is barely 4,000. And what we saw was that the clinics in the Southwest and the South-South and the North Central, Abuja, Kaduna, are growing. They're making money. But we saw that it was probably being driven by banditry and social displacement. And we think that this will not last for long. As Nigeria is being positioned for global competitiveness, the current cartel of power held by Lagos, Abuja, and Port Harcourt may be displaced by 2035 if we do not put darkness, if we do not put light where the darkness is now. Abuja, Port Harcourt are dominating and Lagos, whereas the need areas are in the Northeast and Northwest. So these are the patient load, doctor-patient load in each of the regions. The highest is 53,000 in the Northwest, and the lowest is 3,900 in the Southwest. We need 80% of Nigerians are struggling, and we require affirmative actions for universal healthcare because only 5% are probably above the breadline. The hubs for commercial eye care remain Southwest, South-South, and the state capitals. I guess we can do something. As it is happening in the other sectors, we will one day wake up and find some Asians who will go to Sokoto and Zamfara and begin to blast ophthalmology interventions that will surprise us. Nigerians, the 860 ophthalmologists in Nigeria today do not appear to see the opportunity in the bottom of the pyramid that resides in Northeast and Northwest, but one Asian, one Jim Seung Sang will come and put resources behind himself and learn Hausa language and then invest in telemedicine, and then he will take opportunity over and above our heads. Even though subsidies is required to close poverty gaps, there is need to break into the huge underserved markets in the Northeast, Northwest, and Southeast. We need to conceptualize and operationalize all other alternative channels for patient care through telemedicine, which we call digital-first clinics. After all, I know a young lady who does business, who sits in Lagos and sells across the whole of the country. We can begin to use telemedicine, to invest in telemedicine that will capture healthcare delivery in the Northeast and the Northwest. Hybrid primary care, ambulatory surgical centers, hospital auto model, and other clinic franchising. Eye Foundation, for example, can franchise clinics to people in the Northeast and the Northwest. Indeed, the catalyst for the first mover advantage shall be powered by telemedicine and artificial intelligence. Call to action. I hereby call on our ophthalmologists in the diaspora to use their experiences and wealth and resources to bear on Nigeria, because they are now more experienced. The average ophthalmologist in Nigerian ophthalmology operating, or a medical doctor operating abroad, they appear to have more exposure, training, and access to technology, as well as wealth, to be able to make impact in Nigeria. So I hereby call on our doctors and ophthalmologists in diaspora for interventions, urgent interventions. In order for us, this is just a checklist. When we want to establish a group practice, we need a mindset. We need an abundance mindset rather than a scarcity mindset. We need an ecosystem mindset rather than an ecosystem mindset. We need a capacity mindset rather than just an output mindset, because our capacity defines our productivity. If our capacity is not utilized, if it's at 30%, our output will be 30%. However, if we are able to do to increase our capacity to 70%, it means our output will also increase. So we should focus on capacity. What can a Dr. Odenilo deliver? Then what is he delivering? Of course, we need to look at a lot of terms and conditions which are already well articulated in other areas of business, in industry. The playbook for group practice is already well articulated. It's not new anymore. On the other side, on the flip side, for the people who are going to be recruited into the group practice, we need to focus on technical competence of the people who are going to be recruited into it. We need people with basic goodness, with basic goodness, people with passion. If you are not passionate, you are not likely to be result-oriented. If you are not principled, you are not likely to be self-discipline. So we're going to be focusing on key issues of technical competence of the people we are going to recruit into a group practice team. Because basic goodness drives interdependency. The ingredients of basic goodness are sorry, please, thank you. Those words are scarce. People don't know how to use them. People don't understand the power of those three words. Sorry, please, thank you. It breaks ice. It opens doors that are closed. When we want to do group practice, we also need a synergy mix. The individual talent is a mix in the synergy, accounting for my own experience, about 40% of success of the group practice. The organization is about 50% of the mix, while the environment is about 10% of the mix. So in a group practice, we got to focus on organizational culture, corporate policy, teaming, work-life balance, tool, technology. That, for me, is a 50% chance, has a 50% chance of succeeding. Then the people issues, intellect, competencies, abilities, stamina. And indeed, one particular thing which is tied to basic goodness is personal motive and intent. It's a very major, if we need to do psychometric testing before we bring people into a group practice, in order to understand how their linguistic programming is very important. When I was in Dunlop as divisional head, human capital, before we promote somebody manager, we do psychometric test. It's called neuro-linguistic program test for you to become a senior manager. We want to see how your inner mind is working. Are you a scarce person? Are you an abundant person? Are you likely to be fair? So the power in the individual is about accounts, according to Georgopoulos, in the path goal theory. The power in the individual is sitting on the power in the institution. And the environment is just a bare 10%. The road will be rough, please. I'm not joking. I'm not kidding. But the success in our hands. We also need group practice senses, synergy senses. We need people who has speed with respect to delivery of promises. They must have sense of urgency. We need people in a group practice. If we do not have these people with this type of senses, the practice will not likely to be successful. People with customer excellence. Unfortunately, in my 18 years of working with doctors, I've come to see that doctors, I'm sorry, distinguished participants, doctors are usually should have padded. They take their patients as hostages, with all apologies. Doctors are not generally customer focused. They are technically focused. So in a group practice, that cannot work. That practice will fail. So as you are keeping your technical competence as a doctor, you must develop a sense of care for your patients. You must come to terms with the fact that the customer is the king, and the king never goes wrong. And that when you want to take money from my pocket, you have to first of all win my mind. There's a sense of duty. We are looking for people that will not be supervised bumper to bumper. We are looking for people that have sense of shame. People that when there are problems, they sit up to it and try to rectify however hard it is. we are looking for people who believe in value creation and value preservation, because the two of them are different. In value creation, you are improving performance. In value preservation, you are preventing a leaking basket. Because when you improve performance and you also throw it away, you bring it with the right hand and you throw it away with the left hand. So that is why there's a balance between value creation and value preservation. Distinguished colleagues on this call, for us to ensure sustainability in a group practice, we have to continue to sharpen our input, throughput, and output. But remember, continuous improvement is better than delayed perfection. It's better to start now. You will never be perfect from day one. Dan Tata and Sao did not start from day one. Akintola, Williams, Deloitte, they did not get perfect from day one. I Foundation did not get perfect by day one. As a matter of fact, Kensington Way Clinic, Kensington Way Hospital started from Stradley Walk Clinic by Dr. Dimeji Amulodu. He started from Stradley Walk Clinic, a small investment, and then went into a mighty investment. The Kensington Way is almost 5 times the size of the Stradley Walk Clinic. And the number of partners, there were 2 partners in Stradley Walk Clinic. There are 5 partners in Kensington Way Clinic. Continuous improvement is better than delayed perfection. Group practice, the path to sustainability. We cannot say we are a group practice and we are not properly legal. We do not have a legal personality. We got to register as a legal personality, either as a limited liability company or as an LLP or whatever it is, or as a trust. The Kensington Way Hospital of Dimeji Amulodu is a trust, registered trust. So we have to create very strong corporate governance framework that promote inclusive participation and accountability, build institution and non-personality, invest in corporate development that will culminate in financial prosperity. I repeat, at the end of the day, we are all in it for money. We got to invest in corporate development transparently that will culminate in financial prosperity and autonomy for the institution. Train and empower mentor successors from the younger generations. Promote merit-based culture, gender diversity, as well as work-life balance. And if having achieved sustainability, as part of achieving sustainability, we need to upscale sustainability. Sustainability is a continuum. We are going to find ways to continue to improve it in order to create enduring legacy. So after initial internal equilibrium, the hospital can achieve generational sustainability by establishing a legacy foundation for professional research, training, and development, either in general medicine or in ophthalmology. Collaborate with government agencies and other voluntary organizations, particularly in the underserved zones of Northeast and Southeast. Sponsorship of various initiatives for corporate social investment, particularly for the vulnerable citizens, as well as franchising of the hospital brands, in order to create enduring legacy. The group practice will also need to sharpen the process and partners in the supply chain, because if an hospital does not sharpen its relationship as well as the process of the partners, it cannot achieve sustainability. So we need to my research shows that only fixing pharmaceutical, for example, in the ophthalmology section of Nigeria, only fixing is manufacturing locally drugs for ophthalmology. All the others are imported. So we need to find ways to increase the capacity of fixing pharmaceutical to produce as many drugs as we are currently importing. Or we establish another company, the Consortium of Ophthalmology, OSN can establish another company that will be importing the totality or whatever of the drugs that the ophthalmology will require, instead of everybody carrying their drugs in portfolio and walking up and down the airport. Of course, for you to be successful, we have to sharpen our relationship and enhance local content with respect to biomedical engineering as well as optometry. Our understanding is that there are 4 optometrists to 1 ophthalmologist. We don't want to expand. We do not want to expand that discourse now. But what we projected after interpolating for missing data is that there is a likelihood of minimum of 3 to 4 optometrists to 1 ophthalmologist to support with respect to eye care. The summary of this slide is that we need to enhance local content in order to promote service quality and capacity utilization. The group practice business imperatives. The requirements for success of any business are fairly similar. Either mobile toilets, either manufacturing chalk, whatever it is. Business is business. And the issues are fairly similar. Therefore, medical doctors in business must imbibe and learn the languages of financial analysis, which include, for example, turnover. What is turnover? Turnover is volume, mix, and pricing. They must understand cash flow, because when you sell, when you record turnover and you don't collect your money, your cash flow will suffer. Cash is king. Turnover is vanity if you don't have cash. When you collect cash, you don't spend the money either in operational expenses or capital expenses. And this leads to either a loss or a profit. Profit and loss is simply a contest between margin and cost. Because you don't spend turnover, you spend the margin that comes from doing the business, which we call gross profit. The margin is the gross profit, or divisional or unadjusted AGC, unadjusted gross profit. At the end of the day, doctors must be able to read balance sheet. As it is today, doctors will need who want to do business, who want to be in a group practice, must learn the skill of marketing and sales, customer service, economics. Doctors must know basic inflation. Doctors must know GDP and must be able to do basic human resourcing. Human resourcing means bringing the best out of our work colleagues, not necessarily approving it's bringing the best. That is why I call it human resourcing, bringing out the best in our interfaces and interdependencies at work. On this note, we recommend that finance and general management skills should be incorporated into the MBBS curriculum. And if we have already missed it, doctors should please go to the business school. Doctors should please go to the business school. Please, the more you invest in your capacity, the more the money you are going to make, the more the value you are going to create, and the more the wealth that comes to you and I. I am an alumnus of the Lagos Business School, and I am not ashamed to say that I have benefited tremendously from that training. I was in the Lagos Business School in 2021, SMP 16, and it has been fantastic. That's what changed the scenario. That was why, even as a graduate of geography, I was divisional head, marketing and strategy. I was able to be CEO of a healthcare institution. I was chief executive of an HMO. Because once you build capacity, your limits are removed. You don't have limits anymore. The only limit you have is the limit you set for yourself. Group practice. Earlier, I called for urgent diaspora intervention, and I called it reverse brain drain. One of the major challenges facing our healthcare system in the past decades is brain drain, particularly in their sector. We must actively and consciously tap into the enormous opportunities by luring our diaspora colleagues to Nigeria to invest. Indeed, Eye Foundation Hospital, Nigeria, and Apollo Hospital, India, are good examples of diaspora-led investment powered by Dr. Kunle Hassan and Dr. Pratap Reddy. Warning: foreigners may hijack Nigerian healthcare system. Therefore, one more time, we call on diasporians to please come and invest back home. After all, we are all going to impact on the lives of our people here. In case of Apollo Hospital is a multinational healthcare institution. I deliberately avoided talking about Eye Foundation so that we do not make it look like this is an Eye Foundation discussion. Therefore, I decided to look at Apollo instead. Apollo Hospital, as you are aware, is a multinational healthcare institution headquartered in Chennai, India. The group property is the largest commercial hospital in India. The portfolio comprises of over 70 owned and managed hospitals and other allied healthcare facilities, such as pharmacies, diagnosis. That is the power of integration, value chain integration, diagnostics, telehealth clinics, and so on. The current turnover is estimated about $2.6 billion, and their net income for the period ended March 2025 was 170 million. Note, Dr. Pratap is 92 years old, and he has handed over the practice to the next generation of partners. We're looking forward to a situation in which Dr. Kunle Hassan and all such institutions will also hand over to the next generation. There is power in the synergy for nation building. Some of the hospitals here that have also generated, that have impacted on our lives in the private sector, as in Nicholas, another practice that I understand they have 5 institutions now in that practice. Since 1968, they have handed over to the next generation. Eko Hospital has not handed over yet since 1982. First Consultant Medical Center since 1982 has not handed over. Iwosan Lagoon has experienced a lot of transformation since 1984. Papa and Mama had handed over. Eye Foundation has been here since 1993, and we are in transition. And one of the institutions for this transition is KEFA, Kunle Hassan Eye Foundation Academy. In the public realm, we continue to commend Sacred Heart. These are mostly faith-powered institutions that have generated impact over generations since 1895. Sacred Heart Hospital in 1895, the Baptist Medical Center in 1902, the Seventh-day Hospital, Seventh-day Adventist in Ile-Ife in 1940, the Evangelical Church West Africa Hospital in Egbe in 1952, and the Ahmadiyya Mission Hospital in Apapa since 1961. These institutions, amongst others, give us a renewed hope that we can do better, and the future begins now. I am opportune to read this book, and the title of the book is The Obstacle is the Way. Distinguished ladies and gentlemen, we are going to face a lot of obstacles. We are not kidding. It's not an assumption. We are aware that there will be obstacles along the way. But Ryan Holiday has already encouraged us by saying the obstacle is the way. And he recognized 3 segments of how to overcome our obstacles. The first thing and the biggest issue in our obstacle, according to this diagram, is our perception. Our perception. That is why Stephen Covey said the way you see the problem is the problem. What you see depends on where you sit. What you see depends on what you know. I repeat, Covey had warned us that the greatest challenge to growth is perception. And he puts it differently by saying what you see depends on where you sit on the table. What you see depends on what you know. So we got to change our perception and control our emotions and live in the present moment. I told Frances this morning that I do not know how to do many of these online things. So And she said, I should not worry. It's not difficult. And today I've learned a lot because I've been spoiled by the health partners team. They set up these meetings. I just join. I just move on. So we got to take action. We got to keep moving. No stopping. Keep moving. Once things change, please let us change. And we got to follow process. We cannot be circumventing processes and be hoping that things will work. We have to put our ladder on the right wall before we begin to think of doing right things. If we do not put our ladder on the right wall, we are unlikely to do the right things. And then we channel our energy to the right way. The biggest issue in will is perseverance, and the thinking bigger than yourself. I can see clearly that Dr. Reddy thought bigger than himself. Dr. Hassan thought bigger than himself. I can see clearly. I'm so encouraged. I remember that I had met him from Apollo before, about 2013. They came to Nigeria. They wanted to collaborate with our HMO. I did not meet Dr. Reddy, but I met the team from Apollo. But we aborted that relationship because we just saw that they wanted to be harvesting patients for medical tourism to India. That was why we aborted that relationship. We got to think bigger than ourselves. We got to think bigger than ourselves by empowering our teams, by anticipating what could go wrong pre-mortem and what has gone wrong. We have to anticipate what could go wrong so that we do not put the totality of our body into the water. We have to test the water. That's pre-mortem. And then post-mortem is that when something goes wrong, we now have to check why did it go wrong. Distinguished ladies and gentlemen, one more time, Stephen Covey has told us, has reminded us, there are 4 rules of leadership in any endeavor. We got to look for where we are going. Direction. Pathfinding is about direction. Pathfinding is about the mission. Pathfinding is about the purpose. Alignment is about planning, monitoring, and controlling. Attention to details and problem solving. Empowerment. When I gave my paper to Dr. Denilo to proofread, he told me about the empowerment that he got in the early days of his career under Dr. Hassan. And on behalf of Dr. Denilo and the entire team who went through that empowerment, I would like to join them to thank Dr. Kunle Hassan for his forthrightness, for thinking bigger than himself, by modeling himself in other people, by exhibiting leadership by example, because leadership is everything. Distinguished ladies and gentlemen, thank you for listening. God bless you. Let us continue to participate in teams, because teams are better than individual efforts. Thank you very much.
Wow, thank you very much, Mr. Salami, for this very wonderful and insightful lecture. We appreciate you honoring our invitation at KEFA. Thank you so much, sir. So we're going to open the floor for questions and answer. Please, if anyone have any questions, you can kindly raise your hand up, or you can type your questions in the comments in the chat box, and they'll be read out. So the floor is open for questions now. Thank you so much, sir, for this beautiful lecture. So I have a hand up here from Mrs. Halima Bogunjoko. Please, can you go ahead and unmute your mic and ask your question?
Is Dr. Bogunjoko?
Okay, good afternoon, sir.
Good afternoon.
Please go ahead. Yes, sir.
I want to talk empowerment. I want to thank Dr. Mr. Dele Salami for a wonderful lecture. Thank you very much, sir. I want to also pay tribute to Dr. Hassan, because he has trained many of us. All the training I received from our foundation, paid for by our foundation. And what I am today, I'm very grateful. Thank you so much, sir. Thank you.
Thank you very much, Dr. Bogunjoko. Do we have any questions from anyone in the house? You can raise your hand up. You can type your questions in the chat box. So I have Dr. Ayo Hariman, your hand is up. Please go ahead and unmute your mic and ask your question. Thank you.
Good morning, Mr. Salami. Thank you very much for accepting our invitation. Thank you also, Dr. Hassan, for establishing the Kunle Hassan Eye Foundation Academy. The lecture has been very, very insightful. But one question I'd like to ask, I know you talked a lot about group practice. How can we encourage the younger doctors to get into group practice? Many doctors like to go on their own. I don't know whether it's a Nigerian thing or whether it is a general thing, but I found that many doctors don't prefer to set up their own practice. How can we encourage these younger ones to get into group practice? Is it from while they're in medical school that we talk about it, or as soon as they finish, we start encouraging them, having more and more webinars on the benefits of group practice? How can we do that, sir?
Should we take the questions and then I respond, or I take one after the other? Moderator.
You can go ahead and, you can go ahead and take this. Yes, sir.
Thank you very much. There are cultural idiosyncrasies that appear peculiar to Africans, Nigerians. We have trust issues because of the long period of deprivation and mismanagement. The propensity to distort ourselves is very, very high. So when you hear let us come together, you resort to the iron law of oligarchy. The iron law of oligarchy is saying that when you hear that somebody say let us come together, he wants to shit you new. Whereas coming together has always been the basis of revolution, industrial revolution, commercial revolution across the world. When the same Nigerian gets to UK and he already meets a culture of pooling resources, it will fit in. So leadership is the answer. We need somebody who believes in deferred gratification to pull these young men and live the initial life for all of them. What happens is that when you have such leaders, you will see that at that moment they're pulling them, they are just teaching them, they are just paying them, and transparency will be the beginning. But like you said, how many times are we going to find such leaders like Dr. Azam, who will just pull some young people and then begin to invest in them at the detriment of his own probably personal wealth? It is time to talk group practice in medical school. We've got to be practical, distinguished colleagues. It is time to teach group practice, to put a typical group practice contract on the table. I have not seen the group practice contract at Wellington Way Hospital in Bow, London. But there was a case Dr. Oladimeji Amuludun discussed with me one day. One of the partners needed to exit because of regulatory requirements, because he had messed up his license. His license listed will be revoked, and if they do not report, the entire hospital will be shut down by the regulator. But according to him, those issues and those circumstances were already anticipated in the memorandum of partnership, such that all they did was to organize a board meeting and discuss the subject and refer to the relevant section of the contract of group practice and ask him for his opinion, and he offered to resign voluntarily. He offered to resign from the partnership, and he was now assisted to sell his interest to another person, to another partner. So we need to put those things on the table in a school, in a seminar, in discussions like this, so that people can know that it's not about just verbal promises. Don't worry, I'll send you to school, I'll pay your school fees. Don't worry, I will do this. There was a case of somebody we wanted to send to India. We had Olympus scopes, machines, and there was nobody to operate. We wanted to send him to India to go and learn how to use the Olympus scopes. And at the point of the investment, he started saying that he didn't want to enter into any contract. He just wanted the institution to send him to India to learn about laparoscopy surgery, and then come back and continue to earn. He was earning, as of 2013, he was earning about 1 million naira, and he was living in a company house in Lupeju, and he was using a company car, and the company was bleeding. Laparoscopy machines were down, patient loads, because it was surgery that was supposed to drive the process, to drive value creation. So, so you see the problem of trust. He wanted the institution to send him to India and acquire capacity. Maybe when he comes back, he will just now go away. That it can work that way. For every right, there's a responsibility attached to it. So we have to, leaders have to, first of all, set examples by pulling these young men together. Then that's stage one. Even though that is not sustainable, you are not likely to find so many of such leaders who believe in deferred gratification. If you want to know the meaning of deferred gratification, you have to go and study the case of Lee Iacocca of General Motors, who worked for close to 10, 13 years without earning 1 naira, without being paid, in order to turn around Chrysler Motors. I think it's Chrysler Motors, I can't remember now. But Lee Iacocca, if you just Google www.leeiacocca.com, it will come up. But at the time of his exit, he was paid in millions of dollars. The company calculated about all his benefits, all the things he has not earned was paid, because the company has gone. That's called deferred gratification. When Dr. Zan was riding Mole around in Kumbi bus, I remember that Kumbi bus. So not so many leaders will do that, but we need to start studying, modeling group practice in our institutions, in medical seminars, in KEFA, in NMA, and so on and so forth. Thank you.
Yeah, good afternoon.
Very much, sir. Thank you.
Yeah.
We have a.
Yeah, can
Okay.
Can I speak?
Hello.
Can I
Okay,
speak?
please, who is speaking? Please go ahead.
All right. So, thank you very much. My name is Abiodun Oshiemi. I'm an adjunct professor of business. I teach business in the university, but I'm also a medical doctor. So I want to thank you very much. But I must particularly thank Dr. Hassan, who has been at this for a long time. By the way, my hospital is also Eye Foundation, so I love Eye Foundation and the doctors. So thank you also, Mr. Salami, very much. But I am passionate about this because it's very important, and you've done extremely well. My question will be first, so you don't miss the point, will be, who do you think is best positioned to train and teach doctors on getting into understanding business or not, especially when the doctor doesn't even like throughout the training years to be referred to as a businessman, to be a business professional, or to go into anything business. For over 20 years, I've been teaching certified health business practice and worked with a lot of learned society. But I want to share with you that, so doctors don't like to be called businessmen right from school. They hate the word business. And so the question is it surprising, therefore, many years after school, the reluctance to jump at business you are advocating may be strange? So that's the first thing. And secondly, what kind of returns would these people should be expecting? So it means if I have 1 billion naira, I put it in the market, money market, I can get between 17 to 20. What kind of returns should they be getting into? Because you are a through and through businessman. That's the kind of thing. But beyond that, I'd also like to share, because this is an opportunity to share. So those are the questions for you, sir. I would just like to share within 2 minutes is that in businesses, leadership or no leadership, when people come together, there must be a consensus added them. In other words, meeting of the mind. People will bring different strengths, and they must understand the kind of models and things they've done before. Many times when people want to say, let's do business together, and I thank Dr. Harriman, she invited me just 4 hours ago, and my football team is playing now, Manchester United. I'm forgoing it because this is where I have my passion. So what I want to say is that there is usually no meeting of the minds, number one. Then number two, the labor is usually so hectic. And so these are some of the challenges. And the younger people also now are also in the digital ecosystem. So it's a little bit challenging, but please take the show and enjoy and educate us about those two areas of who will teach people who are taught not to look at business to start looking at business. And in our hearts, we don't like to be called business people. So how do we change this narrative? I thank you so very much. And again, thank you, Dr. Hassan and the organizers, and to all my people at iFoundation.
Thank you very much, Dr. Oshiemi. Incidentally, I appear to know the institution, and I've interfaced with that institution before. I'd like to thank you for the good work you are doing in your training institute, trying to increase the capacity of doctors and health practitioners in business. You cannot beat the Igbo apprentice system. No one has beaten it. Even Harvard Business School it has put a spotlight on the Igbo apprentice system. Therefore, when I was sitting down in HR department as divisional head human resources, and I was just on October 2nd, 2003, transferred to marketing as divisional head marketing and strategy, I was confused, and I went to an executive committee meeting where I was going to present operations report that consisted of all financial languages: return check, this, that, UGC, AGC, divisional contribution, volume, mix. This tire is doing 7% margin, the other one, therefore I have to give manufacturing director that don't produce this tire. This tire is 7% margin. This is the one I want that is giving us 35% margin. And I didn't know how to do it. So I took Akim Oketola with me to the ESCO. And my boss quietly pretended to be going to the bathroom. And he called me from the bathroom to ask me what Akim Oketola was doing in ESCO meeting. And I told him that I didn't know this report. Akim Oketola gave me a report that I knew next to nothing about. I said, no. I will postpone ESCO by 30 minutes. So he told me, go back to Akim. Akim was my controller, cost and management accounts. Go back to Akim, tell him to teach you in the minimum how to present this report. then you can go and be learning from Akim what these things meant. And that changed my life. I sat with Akim in the ensuing weeks, and without even going to business school, I became a superstar in financial matters. I knew about mix, I knew about AGC, I knew about production cost, because in that report, there are also production costs, all those things. I know about what you call service failures, because in the manufacturing system, the manufacturing team takes production defects, but the marketing team, that is the cost of production defects, while the marketing team take the cost of service defect. If you sold a tire and the tire failed in service, maybe the tire busted, when we are replacing that tire, and indeed we normally replace all those tires, when we are replacing those tires, the marketing function will be debited. So, and up to today, I still thank Akim for taking me through those issues. So that's the first response, through apprenticeship. A lot of people are so ego involved that they cannot stoop to conquer. Look at the way I wrote this paper, and I knew that I'm not a doctor. I'm not a doctor. I've never met Fatima Kyari before. I only read about all of these things from papers, presentations. I opened the internet, ophthalmology issues, and I sent these things to Dr. Odenilo to say, please help me to proofread this, help me to fact check this. And he did. That's apprenticeship. So Akim Oketola was my Nelly, because the basis of our apprenticeship is sitting next to Nelly. Nelly is the grandmaster. Akim Oketola was my Nelly in accounting. Dr. Odenilo was my Nelly on this report. He didn't go, he spent his Sunday night to look at this paper. So in everything you are doing, you must have a teacher. Oh, Giaolo and teacher. You must have a teacher. You must have somebody that is shining light, that is throwing light onto your issues. The second thing is that we need to do short courses. And I know you are doing short courses. We need to go to business school. Our colleague in Air Partners, who is a doctor, our current chief operating officer, is going to start SMP 99. The SMP 16 that I attended is going to attend the same course in LBS from the 17th of this month. That's an investment. Over a period of 5 months, that's an investment that Air Partners is making. Individuals can also make this investment. I've just spoken to my external auditor, Messrs. Juma Bigbo and Co. And I said, you are no longer available. What's wrong? He said, okay, I'm at LBS. I'm trying to upscale myself. So people must invest in themselves. It's garbage in, garbage out, input, throughput, and output. The third question, what is the return on investment in healthcare business? My understanding is that return on investment depends on your business strategy. In my humble research and findings on medication, the return on investment on medication is 100% in most hospitals. You buy paracetamol 10 naira, you sell it 20 naira. There is no hospital that does not achieve 100% return on investment on paracetamol, on antibiotics, on fluoxetine, on whatever it is. The average hospital buys something and puts 100% margin on it. As a matter of fact, there's an hospital in VI that puts 300% margin. As an HMO, I see these figures and I know the prices of this thing in other institutions, and they tell me that is cost recovery. Who pays for my this? Who pays for my that? The average UGC means unadjusted gross profit on surgery. In many places, not less than 50%. It's not even 50%. So there's the business of healthcare is profitable. Excuse me. It depends on your market. Are you operating in the budget market? Are you operating in the top-notch market? Are you operating in the middle? Whichever way. While the top-notch market will not give you paracetamol, will give you paracetamol made by Beecher in London. That is what they just do. And they buy it. How much is it on the streets of London? A pack of 20 paracetamol is probably £3. And they convert the £3 to 6,000, and they come and sell it to you in that same hospital at 15,000. I've seen such a hospital before that gave me Beecham London paracetamol in Nigeria and charged me 15,000 for 20 pieces. So the ROI on medication is usually not less than 100%. The ROI on surgery is usually not less than 50%. The ROI on inpatient treatment is not less than 40%. Yesterday, like I told you, I told you on this call, I gave an authorization to an hospital yesterday for consultation. The surgeon wants to take 40,000 naira consultation, and the hospital charge 60,000 naira. So there's a 50% margin on consultation, depending on that specialty. So everything in the hospital is likely to be profitable. The hospital business, you need to locate in a proper place. Location, location, location. Then segmentation, segmentation, segmentation. Then business development, business development, business development. The business development issues are as a result of the efforts of the doctors to win the mind of the people before they focus on the pocket. Once you win the mind of people, you have earned your trust, you have earned their trust, you are able to win their pockets. They don't care anymore. Excuse me, thank you. Does that satisfy?
Oh, yes, thank you very much. You couldn't be better. I'm really proud of you. I'm really proud of you. Thank you so much, sir. Thank you so much, sir. Well done.
Okay. Thank you. In the interest of time, we'll quickly take other questions. We have some questions in the comment section. This is from Dr. Dada Teresa. It says, inspiring talk. Thank you very much. A lot of food for thought. And the question is, are doctors technically focused because of obstacles and difficulties faced in setting up, and therefore the need for profits to survive being the drive? Should I take that question again, sir?
Yes, please do.
Yes, the question says, are doctors technically focused because of obstacles and difficulties faced in setting up, and therefore the need for profit to survive being the driver?
Okay, I understand. The way I understand it is that why are doctors focusing on survival? It's fear of the unknown. I understand. I can understand the fact that you need survival first before you can do development. If you look at Abraham Maslow, the first issue is survival before you begin to talk about the hygiene issues. It is when you have survival that you begin to think of hygiene of self-respect. If you don't have survival, you cannot be expecting respect. You cannot even respect yourself. So doctors must understand that yes, there is need for survival, but survival has to be the foundation for growth. The fact that you are already alive, you are already surviving. No pain, no gain. The more the risk you take, the more the quantum benefits that you will derive. Dr. Teresa, for those who want to do group practice, they generally, for example, when I started Campbell Heights, I did not draw 1 naira out of that company for 18 months. I was surviving on whatever little. Immediately I retired in 2019, I was surviving on the little that I had saved, because that company needed to survive first before I begin to charge to it. So the board of Campbell Heights had an understanding that when we make money, Mr. Salami, you'll be paid back what you are supposed to have taken in the 18 months. So we commenced business on the 22nd of October 2019, and we're making money. We're making money. Now I'm able to earn steadily, but for the first 18 months, I did not earn from that company. I was living on my resources. So that is the way group practice will be done. So the investment is in the business, then we survive. Our means of survival should not be immediately tied to the business. That is why these businesses are failing. You start a business and you are immediately tying your survival to it. That is the power in the obstacle is the way. That is part of the issues. Please go and read this book on how to survive that problem. The obstacle is the way. So it will help for us to change perspective and redefine priorities. Dr. Teresa, I hope I've been able to answer your question, albeit as much as I can.
Okay, thank you very much, sir. I'll take another question from Dr. Dupe Ademola Popoola. She said, thank you, sir. It was good listening and thought-provoking. And she has a question. Her question is, sir, do you think starting together from the beginning is the best, or one starts and then bring together others? Also, what about sustaining the group?
Well, if you recall the story of Hewlett and Packard, the computer guys, they started immediately in the university. They left the engineering school, meaning they were peers. If you check the story of iFoundation, they were not peers. They were brought in and somebody invested. But these ones, Hewlett and Packard, invested in themselves concurrently. So it depends on who is leading the process. It may be good if you have long-time allies and the aura works together. Because remember in the synergy requirements, we want people with basic goodness, and we even recommended that we should bring them in after benchmarking with all those parameters that we have set. Technical competence, character, this, that. That's called aura. At the end of the day, you're able to work together. So when it happens like that, you can actually start together. Your peers. In Stradley Walk Clinic in Bo, Dr. Oladimeji was not the one that did it. It was brought in by a far more senior person who had left. I'm told you about it, something years old now. He has left. He's enjoying in Paris. He handed over to Dimeji. Dimeji brought another person before all of them went to Kensington Way, also in Bo. And they're pulling resources. Pain Clinic in South Africa, he brought them in. He brought all of them in. Whereas in 4 ways, it was an investment company that brought all of those people together by providing site and services in 4-way hospital in South Africa. That group is now known as Life Earth Group of South Africa. So your model will be defined by your vision, by what you can see. That is why we say we should live in the present. If you check the summary of the slide on the obstacle is the way, you should look for opportunities by living in the present. You should take opportunities that are available in the present. Hey, gentlemen, if it doesn't work, you break it and move on. Then you improve on it. Because there must be room for exit and exit. There must be times, please. I think the next, like Frances requested for another topic, I think we should put another topic on extraying group practice, operationalizing group practice. We should look for somebody who has done group practice and make it another topic on how to operationalize group practice. KEFA should sponsor a program to bring doctors together on how to operationalize group practice.
Thank you very much, sir. I'll quickly take the next two questions. Yes, there are more questions, sir. I'll quickly take the next 2 questions. We have another from Dr. Dada again. She said, does Nigeria have the infrastructure for telemedicine to survive and thrive? as this will be a good way to reach many. Also, education is key when dealing with the population, as there will be costs incurred on the side of the public to use this service. So the first one is
Nigeria has infrastructure for telemedicine. We may say it's not adequate. I'm aware of Ella Health. Ella Health is a telemedicine infrastructure that you can just call in and then you get responded to by a doctor and prescribe drugs and so on and so forth. It's not adequate. It's an emerging market. It's an emerging market. But whatever it is, the journey has started.
Okay, then the second part.
Yes.
The second part of our question, I think it was a two-part question, sir.
I missed that.
Yeah, the next part was also education is key when dealing with the population, as there will be costs incurred on the side of the public to use the service.
Yes, I agree. Education is important. However, service excellence itself is education. When you treat a patient well, or you treat somebody very well, it's likely to tell others that he has been treated. So that is why in business, we normally say that the cost of recruiting new customers is far more than the cost of retaining the current ones, existing customers. So we use our existing customers to market our initiatives. Today, people have WhatsApp platforms. You can buy 1,000 units of text messages for those that are not on WhatsApp and broadcast messages to them. You are marketing. You are educating them. You are doing all sorts of things. I mean, yesterday I received the invite again for this call on WhatsApp. It means KEFA has the telephone data for people who have participated in the past. So it's not uncommon to use, if you don't have money to do proper large-scale mass media interventions, you can start from your sphere of influence. That is the power of the environment. The theory of environmental determinism has been defeated, distinguished colleagues. The environment can only determine you if you are not determined. And that is why it has been relegated in the path goal hypothesis to 10%. The individual motive is 40%. The organizational impact, the power of the organization is 50%. So when you put 50 on plus 90, you already have to plus 50. It's already 90 over 100. 10%, you can always overcome the environment. If you don't understand how to overcome the environment, other people in your team would know how to understand the environment. We respond to the environment differently. So our encouragement is that we should not focus too much on the environment. It's just an area of concern. As it affects you, it affects everybody. So those who gave excuses of environmental determinism are not likely to be successful. We are now talking of environmental possibilism. What is possible within this environment? You have to look at what is possible within this environment. Does that satisfy Dr. Dada?
No response. Okay, so let me move on to the next question, sir. So from Dr. Opola, she says, I assume that the business school will have various departments, modules, and units. Which of these would you recommend to a doctor to be of top performance in business?
The first course that I attended in the Lagos Business School, it was called trade marketing, because I was moved from HR to marketing, and I did not know what to do anyway. So after some time, I was sent for trade marketing. And then by implication, what I'm saying in essence is that there are so many courses. And indeed, I appeared to see Professor Chris Okpeche, who was my teacher at Lagos Business School, on this call. There is a health sector program, health sector focus program at the Lagos Business School. And I know Dr. Oshiemi on this call, our friend who called earlier, has a training center that is focusing on retraining health workers in business. And it doesn't have to be Lagos Business School. There are so many short courses that we can attend. Accounting for non-accounting professionals. I also attended that course. Finance for non-finance executives. I attended that course. So we need to look at the problem we are trying to solve and make recommendations. We can always talk. I mean, the world is now a village. There's a technology convergence on our hands. When I'm looking for people's numbers, I don't deliberately. I'll ask for it. I'll go for a typical email. Most typical Yahoo Gmail today. If you put your cursor on that mail, the telephone of that person is likely to be attached. So a lot of opportunities are there for you to ask questions. Please let us ask questions. Let us ask questions from others. But Lagos Business School has a health sector focused set of training programs. And the issue in business are not focused entirely on health. They are, like I said, they are fairly similar. Most of the issues are fairly similar. You only need adaptive thinking to use it wherever you get to. I was in tire business. It's not as if I've actually I've not done so much in terms of training in terms of new management training. I've just been doing adaptive thinking. My core training was the training I had received in Dunlop as a student of business that converted me from a professional person to a business person. Because if you are focused on your profession, you will not be a business person. You will not know how to collect check. You will not know how to focus on customer. You will just say, "Hey, Mr. Salami, you have glaucoma. You have appendectomy. Lie down there. Remove your pants. Lie down." We remove your pants without saying, "Please, I need to examine you. If you don't mind, you will need to remove your underwear so that I can examine you properly. Even if you don't want to, you can just put it down a little, but the examination will not be thorough." That is customer focus, not lie down there and then begin to fiddle with my dress and say no, customer focus. So translating from being a professional, it's something. If you see a professional, they have very strong mandations. Somebody came for a check to come and collect a check on the person. Well, your money is not ready. No, that's not how to do it, Mr. Accountant. So it's not about doctors alone. Everybody needs to learn this thing. There's always something to learn. That is why we call it learning. Learning is a lifelong activity. I hope that meets the requirements or expectations of Dr. Bola.
Thank you very much, sir. The last one is from Dr. Brown Doreen. I think the person's hand was up before, but the hand is down. But they've dropped a comment saying, "Many thanks, Sir Oladele Salami, for this insightful presentation, and thanks to all the organizers." And the other comments are, "Thank you for your response, food for thoughts. Well done, very good presentation topic." So I don't know if let me see, I think I'm seeing some, okay. Thank you again, sir. So just appreciation messages just coming in. So we've come to the end of our 19th lecture of the Founder Series. We hold this lecture once in 3 months. So we'll be communicating when the next lecture will be. We would like to thank Mr. Salami for honoring our invitation, for giving your time and the very beautiful lecture you've done. We'd like to thank everyone who took out time from their precious weekend to join us on this call. And we encourage you, if you've missed any sessions in the last series, this is the 19th lecture, you can please go to the Kunle Hassan Eye Foundation Academy YouTube page. There you see all our previous lecture series and our subspecialty series as well. So thank you all once more for joining. We really appreciate you for your time. Thank you very much, sir, Mr. Salami. Once again, thank you, everyone. Thank you.
Thank you.